Good afternoon, everyone. Just do give us a minute before we get started so we have more people that can join. Thank you. Good evening, everyone. It's an absolute pleasure to welcome you to today's webinar, Reimagining Professional Pathways for India's Health Workforce. I'm Lakshmi Sethuraman, Head of the Health Practice at Sattva, and I will be your moderator for this session. Today, we're going to be exploring a really important area in the health sector, which is the critical need for pathways to improve career mobility and growth for non-doctor cadres, which include nurses, allied health professionals, as well as frontline workers like ASHAs. I'm really excited to introduce our esteemed panel of experts who bring rich experiences and diverse perspectives to this conversation. First, Dr. Gayatri Vasudevan. Gayatri is the co-founder and chief impact officer at Sambhav Foundation, which focuses on enabling livelihoods for people in the informal sector through education, employability, and entrepreneurship programs. Her work has already impacted over 500,000 lives across India. Gayatri is a member of the National Skills Committee and National Sports Committee at CII, and has previously been a member of the Aadhaar Committee, as well as a member of the Recognition of Prior Learning Project with the Ministry of Labour and Employment. She's also an advisor to NSR Cell, a leading tech startup hub at IIM Bangalore. She's received several accolades, including being recognized as one of the top 50 most powerful women in business by Business Today magazine, as well as in 2018 by Forbes as an entrepreneur with a social impact. Next, Dr. Nachiket Moore. Nachiket is a visiting scientist at the Banyan Academy of Leadership in Mental Health. He's an economist by training and has been at the forefront of designing national and regional health systems in India over the last several years. He's also a commissioner on the Lancet Commission for Reimagining India's Health System. Beyond this, Nachiket also serves as an independent board member for several organizations, including the Swasth Digital Health Foundation, as well as Narayana Hridayalaya. And finally, Mr. Ratish Balakrishnan. Ratish is co-founder and managing partner at Sattva. Ratish is a thought leader in the social impact space and has been instrumental in conceptualizing and implementing large-scale solutions that bring together governments, civil society, and the private sector. He's been actively involved in national policy discussions related to education, skill development, and healthcare. Ratish is also a published author and an expert in systems design. Thank you so much, Ratish, Nachiket, and Gayatri for joining us today. Really looking forward to your insights in the discussion. Before we dive in, I'd like to set some quick context for today's discussion. So contrary to popular belief, we don't actually face a shortage of health workers in India. For example, our doctor to population ratio stands at about 1 to 834. actually surpassing what WHO recommends in terms of 1 to 1,000. We have over 35 lakh nurses, close to 10 lakh ashas, and over 2 lakh female health workers employed across the public and private sectors. Yet our health system continues to remain inefficient and overly dependent on the doctor ecosystem. Non-doctor cadres are vital to India's healthcare system, and yet they often face obstacles such as a lack of recognition for their skills, limited aspirational growth, and inadequate compensation. Many are stuck in the same roles throughout their careers, even if they acquire newer competencies. For example, ASHA workers once recruited typically stay in the same role throughout their careers without any formal pathways for skill recognition or any sort of upward growth. So the goal today really is to discuss what actionable pathways are available to enable career growth and mobility for these cadres, and of course, with the aim of ultimately improving health system outcomes. We are not focused on training, but more on accreditation and certification and how they can enable these cadres with this objective. We've received over 60 plus questions from the audience, many of which align with today's focus, and we will cover them throughout the webinar. Please also feel free to leave your questions in the Q&A box, and we have set aside time towards the end of the discussion to ensure that we will address some of these key questions as well. So without further ado, jumping right in. So before we actually break down what this means for the healthcare system, I think Ratish, this starting with you, how do you think we should fundamentally be thinking about talent models more broadly? Ratish, you're on mute.
Yeah, thank you, Lakshmi, and it's great to be part of this panel. It's great to be on a panel with people like Nachiket and Gayatri, who I think I've grown up reading and understanding the sector from. So just to your question on the talent pathways, Lakshmi, I think that for me, there are a few building blocks that are necessary for a well-functioning talent pathway that we have to build. The first primary constraint is really observability of talent and observability in when there is a shift in a person's ability to deliver a particular job or a responsibility, right? And that observability usually has an upside, which means that the person, when they achieve that observability, are able to see progress in their career pathways, etc. And there are mechanisms that govern this transition from one level of career pathway to another, right? And typically in the jobs that we have in the formal sector, I think we've been able to crack the system to a certain extent. So everybody sort of knows to say, okay, I join as an associate, I will move as a lead, then I'll become a manager, then I'll become a principal, and potentially then join the leadership team, etc. The pathway is very clear, and the discussion on what does it take to move to the pathway is also very, very clear. And if you sort of superimpose that thinking around the health systems right now, and I know Nachiket and Gayatri will cover that in more detail, the problem is that in most of the health systems, the observability is not very, very clear, right? A significant part of philanthropic capital today is actually spent on training. And you said in your introductory remarks that we don't want to focus on training. And we often believe that people are not smart enough to recognize that training is important to them. But I think people are recognizing that there are no incentives for training today because the training does not result in a certain observability for them in how their skills have actually improved. And ways in which their skills are improved are not observable to the system today, right? And for us to discuss pathways, career pathways for talent in the health system, the first question that we have to ask ourselves is, how do we make skills observable in a way that the system can respond to it and provide incentives for them to improve their skills that will enable them better career pathways? And I think that sort of sets the foundation for us for the conversation today, Lakshmi. I can speak more, but I'll come back to this at a later point.
No, I think very useful, Ratish. And I think it's a good segue to, go to Nachiket. And Nachiket, in the context of this, also looking at how does this apply to the health system, right? And I think Ratish also touched upon, some of the more formal workplaces and where these paths are already defined. But in the health sector, and particularly when we are looking at non-doctor cadres, where do we stand in terms of observability, Nachiket? And if you can touch a little bit upon that, both in terms of recognition, in terms of compensation, in terms of performance, that'll be great.
Thank you, Lakshmi. Wonderful to be on this panel with you, Gayatri and Ratish, and with all these participants that have joined us to discuss this very important issue. Building on both what you had presented earlier and what Ratish said, the reality is that we have right now, principally at all levels, including doctors and nurses, only a framework that is based on examinations, based on what training was given and what you tested against that training. The actual observability of competency to perform, what in the UK system is called the Part B, is actually missing in several of our evaluations. If you see the UK's approach, the FRCS, it is entirely the opposite approach. It is not a training-based approach. It's a competency-based approach. And certainly, if this is the situation with doctors and nurses, the situation, as soon as you go away from these two cadres, where the focus is on controlling who enters these cadres, and then graduating people, a narrow stream that enters these cadres on some national basis or other basis. We know that for the health system to be effective, you need actually to be very place-based, very geography-based, very tightly focused on culture, on emotional connections that people have with communities. So you really need a different system to actually take all this capability down to the ground. That capability, as it turns out, thanks to all the pioneers, and India has been actually one of the leaders in thinking about the community healthcare movement. The number of conversations I've had with people around the world that have said that they have been inspired by the movements and the health worker movements from India to really build their own cadres. So in a way, we have no shortage of experience and personnel on the ground, depending on how you count it. If you include ASHA workers, Anganwadi workers, pharmacists, all the hundreds of NGOs that each in turn deploys community health workers, my suspicion is we are looking at somewhere near 2.5 to 3 million health workers, which is, as you pointed out earlier, a more than adequate number.
Right.
But the reality is that we have, one issue is, are we treating them fairly? But if we were to take the view which said, okay, let's worry just about the interests of the health system, are we using them in the best way that we can? My argument is we are not, because of exactly what Ratish said. We have no idea what they can actually do. We have roughly a sense of what the job description was. We have roughly the sense that within the 2 or 3 day training program that we gave, or the week-long training program that we gave ASHA, what did we attempt to impart? But what did they pick up on the job? And if they were all uniformly, capable, then you wouldn't worry, because you would say, I just need to know one person that allows me to know all the 3 million. The reality is there's enormous variability.
Right.
There are some really highly skilled people who have benefited from years and years spent on the ground. And there are others that perhaps have not been able to engage as closely with the tasks that they were assigned to.
Yeah.
And that is the unfortunate reality. Now, that builds a vicious circle. As Ratish was saying, you don't see the value of training. You don't see career progression. So you don't invest in the training. You don't show up for the training programs. Or if you do learn something, you're not bothered. On the other side, it also makes employers somewhat complacent, because this person is stuck. They have no ability to signal that they have the ability to do more, which means I can continue to underpay them, continue to underutilize them with no real consequences. So we are unfortunately stuck in this unhappy place where I would say low recognition, low incentive, therefore to train, and therefore low training.
Right.
Other countries have built powerful channels And we can certainly talk about them later on.
Yeah, no, I think fair point, Nachiket. And I think the point on what you're making in terms of also effective utilization of these cadres is an important one as well. So it's not that, they don't have work. They are, in fact, overburdened at one level, but at the same time, how effectively can we actually utilize them? We're not, and the fact that you pointed out in terms of them being able to do more is really something that we are not able to recognize. And that just goes into one of the pieces that we want to talk about more actively today, which is looking at recognition of prior learning as a tool to be able to address this. And, to you, Gayatri, I think given that you have been part of the movement of recognition, RPL more broadly, right, across the country, would love to get your thoughts on, where you think in the health context does RPL really actually fit in, and what is important for us to keep in mind as we think about this as a potential pathway.
Thank you, Lakshmi, for inviting me, and really good to be here listening to various viewpoints. So I think actually the recognition of prior learning would be the best fit for the health system, because this is one where experience, observation, and what one learns through months and years of practice can be best applied. Right? No, I mean, you can't apply it to something extremely where it is only technical. Here, there is a human emotion versus a diagnosis and a care. All three are involved. But sadly, I think when we look at recognition of prior learning, we're looking to test against a learned knowledge, which means that all the ways of assessment. So if you had to credential, how would you credential, right? It's very, very important to actually establish the manner in which one would recognize prior learning in a sense, right? Which means the assessment system needs a lot of work. One needs to look at it from that perspective. Today, the way we administer recognition of prior learning is, we say we've already defined these are the tasks which we want to test knowledge. Tasks should not be married with knowledge. Outcomes are very different. Like, for example, if I was taking care of a 10-day baby versus taking care of somebody who is 95 years old, just taking two extremes, could be both caregivers, which in our language we would call general duty assistant in the quote-unquote skilling world. But that's not a job role. The job role for both differs a lot. One is, the what one has to look at differs a lot, and therefore the differences need to be measured accordingly, which means outcome matters and not necessarily only knowledge. Whereas all our testing is towards knowledge. So one has assumed you have given a 4-page note, which you have learned, and which unfortunately, I think the digital access has further complicated, right? We've all made it multiple choice questions, which is very sad. Right. So observability, there has been a lot of work and research which has been done on observability. Peer-to-peer observability, which is, so that means you can test peers. You don't necessarily have to have a single mechanism of testing, right? 4 ASHA workers could come together with the ANMs and form a peer group, and then they could do testing. How do you do those observations? I'm not talking of any, very radical steps, but I'm saying these are established methodologies that are available. You apply it in management as group discussions, but you could take case histories and this marry it together, make it work. You could have observation itself. There is observership in young medical students. How do we bring it to other forms that are there? So I think the larger question actually isn't what is RPL? It is what are we trying to establish and why are we trying to do? So if RPL we say is important because the country needs caregivers. I'm not using the word medical at this point because it could, it could be a whole range of them, from preventive to curative. So I'm just saying that if we say this is the group one has to deal with, then I think the entire thing will change. And I just want to make one more point is the incentivization. So for these mechanisms to be accepted, there is incentivization.
Right. If you can just hold on to that incentive piece, I think, it's a very important point, and I just want to come back to that. But before that, I want to touch upon also a little bit about the why that you spoke about, right? Why RPL is important in this context. And I think, Nachiket, just coming back to you here, if you can also highlight a little bit around, the kind of skills today this community is actually building, and therefore the need to actually recognize these skills, that will be great.
So one of the things we know now in primary care, more than anything else, because that's really where much of the domain is, that historically we believed that what was important was skill diagnosis and prescription. And I'm not saying that's not important today. That continues to be important. But now that has become much, much easier. Protocols are there, tools are there, other instruments are available to you. What you do need is certification that these workers are able to use these tools and are legally qualified to do so with whatever safeguards that are necessary to do. But what is most important now, as Gayatri was saying earlier, that we know that primary care outcomes are not doing well because people are either not seeking help on time or, having been given a diagnosis and a prescription, not staying on them, or lifestyle modification. Countries that have done the best job of controlling non-communicable diseases, maternal child health outcomes, have figured this out and have realized that what you need are outreach in a fairly high quality manner, highly engaged manner, in persuading people, in trying to understand what's going on with them. There could be barriers that you're not aware of as an outsider, which is why a local person is essential. A local skilled person is essential. And a local certified person is essential because they are now representing the formal system to this community of people with all the access to referrals, all the access to tools that it implies. So there are many skills that these people already have that they've learned on the job that actually need to be now certified so that they can, start to demonstrate and feel valued for the actual capabilities that they have built.
Absolutely, Nachiket. And I think that, Gayatri, coming back to you, before we get to the incentives part, right? Even in the execution of RPL itself, right? So today, given your experience, even looking at other sectors and so on, while conceptually it exists, there is also a policy framework. And if you can talk a little bit about what really is the enabling environment for us to be able to execute this, right? Are there mechanisms available? Are there tailwinds that we can actually leverage as we go forward with this?
So I think the biggest tailwind we have is the infrastructure which is being created. India has always been good at it. So there's a lot of primary healthcare, wellness centers which have come in. Access at the urban level is also there and not there. It's a cost problem which is there in certain elements. We've divided it between curative and preventive. So I think the whole public health is not taken very seriously. So I think a lot of cadres, if they actually moved towards looking at health holistically, it's possible to do. RPL itself, I think, has been reduced to a government scheme, which is the single biggest obstacle we have today. I think it needs to move towards credentialing for competencies. And as I was saying earlier, and both Nachiket and Ratish were talking about it, but the key is what are we trying to recognize? See, assessment mechanisms, you can always draw parallels and make it happen. But if we are going to assess against a learned knowledge, then we automatically end up with problems. The second problem I see is if we put pre-qualification as the main entry barrier, again, we've lost the battle. So I think we need to get away from our entry barrier problems. And then, open our minds. Then it's easy to design. I'm not saying it's easy, but it's possible to design a system which works. And I think in all we all know that there is going to be a health impact, right? Climate is a very, very major reason for it.
Right.
And then, of course, development, consumerism is all going to result in very different ways in which health is going to be impacted. Possibly somebody said this 100 years ago, and we're saying this in this generation again. But I think the point I'm making is we've got to get away from thinking of it as passing a exam. We've got to think of it as a consistent, a competency measurement is something which you do consistently and continuously through your career, and there is an upward mobility because you do it. So that can be lateral, horizontal, one can work those systems out.
Yeah.
But measurement will happen only when we accept credentialing does not mean knowledge testing. It needs to be competency measurement, which is widely accepted.
Yeah, no, and I think you also bring an important point of, and maybe and Nachiket, back to you as well. If you can talk a little bit about the credentialing piece specifically, right? And how that can impact this community. And if you can also share some examples, Nachiket, that exist today, even globally, but also specifically in India. I think the audience would love to hear that.
So the good thing is, thanks to the efforts of people like Gayatri, we have now a national skills quality framework. There is a framework that recognized in 2013, almost a decade ago, that it is possible that there are young people, senior people acquiring skills that can be credentials that can be, if necessary, equivalent to formal college credit or school credit that they have. That's clearly a powerful mechanism. The new education policy also recognized this as a possibility. What Gayatri said is very important, though, that we have to be clear, what are we credentialing and what are the mechanisms that we are using. Now, my sense is that there we have a lot of opportunity as we go forward, right? Within India, if I look at the school system, my favorite example is the Center for Teacher Accreditation. They are willing to accept and they require a video of you teaching in order to recognize that you are a good teacher. And there is all kinds of testing that is possible. In a health context, the peer thing that Gayatri mentioned, I had not thought of it, but very powerful mechanism. There are many non-profits, there are many organizations on the ground, virtually in every district of India, that one could empanel, one could make sure that they are properly accredited, and they start to actually offer the credentialing capability, because some skills will have to be tested. Do you know how to draw blood? Do you know how to measure blood pressure properly? Are you able to use a retinoscope? Well, you might have learned it, through your various exposures and things that you were doing, helping out this doctor, helping out that nurse. But in order to say that you can do it independently, somebody will have to evaluate whether you can actually do this or not. And the good thing is that there are, many local and international examples that we can learn from, right? Globally, if I look at, for example, the Alaskan Community Health Aid, right? This is a 40-year-old program, formally recognized by the US medical system as a health worker, high school graduate, who receives training in 4 one-month modules. So not long, not 2-year programs, 5-year programs.
Right.
And she's seen as a person that is trained to use equipment, to use protocols, and evaluated against that. Now, credentialing is the first part. If you have already learned it because of your exposure, we credential you. If there are odd gaps that are left in your capability set, you can decide, do you want to train for it or do you want to go back to work? Right?
Yeah.
Countries like Ethiopia have gone quite far, and I'm not certainly recommending we go that far, but they have recognized that, for example, for trachoma surgeries, for emergency obstetric interventions, they can't produce a surgeon in every location, and they have trained, non-medical professionals to do it. So I'm not saying we should go that far, but that's clearly the extent to which a country like Ethiopia has gone.
Right.
In India, there are multiple programs that are, following this approach. And there is Swasthya Swaraj that has worked with Centurion University to develop the diploma in community health practice. There is the Banyan that I discovered recently, has a program with the Madras University, which certifies people in mental health practice. So really, these are many examples that one can learn from and one can imbibe to develop the kind of certification that Gayatri mentioned, which is talking about relevant skills. But it's very important that it's seen as a part of a career pathway.
Right. Exactly.
This is the goal is not that I got the certificate, I framed it on my wall, and that's it.
Yeah.
I mean,
Absolutely.
what I've been telling you in the past, Thailand started with the ASHA workers that we have in 95. Today, they are oncology nurses.
Which is fantastic.
Because they have given them the opportunity to graduate up the chain based on the skill sets they acquire at each level. Right? And that is critical because otherwise you're not going to be able to have the talent you need.
No, that's a really important point, Nachiket, right? And I think I just want to go back to Ratish on, to this point, Nachiket, on what you said in terms of that pathway. Ratish, how can we actually think about linking outcomes as we create these aspirational roles? It'll be great if you can throw some light on that.
Yeah, no, thanks, Lakshmi. So one of the things that we should sort of think about is, see, there are a set of people in this meeting who are listening who think this is a very important problem to solve. But for a lot of people, this is not the highest problem to solve in their attention economy. Like the government is not going to say, creating pathways for health workers is my biggest problem. Same as for everybody else, right? So one of the things that Gayatri briefly talked about incentives, and it's incentives for everybody. Like, why should a health worker care about it? Why should the government care about it? Why should the citizen care about it? And that is really what is required for us to push this through. And in my opinion, hence, thinking about incentives from everybody's perspective is important. I think Nachiket rightly highlighted that career progression is why they will want this certification to happen. If they know that if I do this certification, I'll get paid more, I'll get greater social respect, greater responsibility, they're going to go for this. But from a system point of view, it is also important to recognize that, hey, we need a cadre of people to solve for a particular health outcome. The cost of acquiring that talent outside constantly and building an entire system for that is going to be expensive. If there are ways in which we can make that progression happen from internal systems, it becomes easier for us, right? So the articulation to the government or the public system or even the private system is not that, hey, you need to provide careers for young people or workers. It is that, hey, we need to create better quality delivery for XYZ problem in the system, right? And once you start that question, you then come back to the talent question, and this becomes a way to address that outcome that the society and the community is looking for, right? And so if we all agree, for example, that we need better diagnosis and screening of high-risk pregnancies as an outcome across the country, we need people who can screen and diagnose high-risk pregnancies way better. That becomes the need for which the talent sort of becomes a solution. And I think the need for us is also to be able to find those right outcomes, etc., that we have to solve for. I'll just make this one last point, Lakshmi, because it's related. Because again, as somebody who's worked on health and non-health, we've solved the problem of how do you get these, let's say, elitist cadre of talent in some form, right? Which is you train them on algebra, you train them on things that they'll never use in life, but just you create a certain level of mental plasticity and say, any kind of problems you will be able to solve. So the BTechs, the MBA, all of that has worked very, very well. The administrative cadre, which is the second type, it also works well because you sort of give them more and more responsibilities. But across sectors, and I think Gayatri will vouch for this, on the skilled landscape, right? The landscape of talent, which is primarily recognized by skill, we haven't cracked this problem very, very effectively. And examples of where they have cracked it is where they've been able to translate a value proposition that offers better value. Asian Paints did that with Color Academy, for example, right? Urban Clappers today doing that with salon services, etc. It is that articulate the value that you want to deliver better and prepare the cadre for it. And that sort of sets up the incentive models for everybody in the system to be able to make this happen.
Can you just expand on one of those examples, Ratish, just to, explain exactly what we mean by that value?
Yeah. So here's my, okay, this is going to be a slightly longer answer, but, hold me, just give me some time. We've always thought about the fact that when you skill people, industry will accept it. And then over a period of time, industry will invest in skilling. And where did this assumption come from? This assumption came from the idea from the East Asian countries, where in South Korea and other countries, government invested in skilling. But the one thing that government did there is to say that, hey, I am giving you skilled people because you can play in the export markets. So the value that the government held the companies responsible was to play in the export markets, and skilling was the input, because that skill created higher value for the companies to be able to deliver better outputs, etc., and better quality, right? In India, we improved the skilling side, the supply side of things, but very few cases where companies are able to articulate that the higher skill is actually resulting in better value for people, right? And because that value was not articulated, skilling was just seen as a staffing supply problem, right? Asian Paints was one example where they said, listen, I'm going to train these people, but I'm going to make my painters into somebody who can come and advise you on the color you can use, the room, and they gave them these little gadgets. The quality of experience improved, customers willing to pay more. Asian Paints articulated a business model around it, right? Look at companies like GE, right? Cisco, which is that they had network equipment that they put in. And they said somebody has to use this equipment, business problem, talent automatically got upgraded. And hence figuring out this model of the incentives that will work for the customer, incentives that work for the system and for the worker is really the part about making this happen, rather than just seeing this as a skilling or a certification problem, Lakshmi. I hope that was helpful.
No, I think that was very helpful, Ratish. And Gayatri, coming back to you here, right? I think if you can also, you did have a point on the incentives piece as well. I think if you can expand a little bit around that. And I did have one other question for you, which I will just come to.
So, I'm just going to now talk to Ratish in that sense. So let's look at it from another perspective, right? Almost 2.5 lakh villages in India are economically unsustainable. That means they're not going to be serviced by traditional economic models. But that doesn't mean prosperity hasn't reached them. They want the same health outcomes that all of us want. Who is there in the village? Largely, it's women in the village. I'm not coming to whether we going the right economic model by migration, etc. I'm not addressing that issue. But I'm addressing the basic issue that young, able-bodied women exist in the villages, which means that if we were able to imagine recognition of prior learning, accreditation differently, we could have an extremely satisfied populace, right? That means the health systems could be reaching large number of people. The women could be good, quote unquote, employees, workers. Today we've tabled them. So it's a hierarchical system where the Asha is told by XYZ on what has to be done, and she does it routinely, and then we bring in multiple tech systems to tell her what she already knows. I'm telling you a reading which you already know. So it's not about just ensuring that somebody knows to use and is able to bring readings, but it's what problems is she asked to solve. So I think if we look at it, it will solve a public health problem. It will solve an individual health, the journey of each individual as a patient's health journey can be very well chronicled and solved for, and it's an employment generation. But today what happens is we have to bucket them into training modules. And that's because we understand education. So what we are trying to solve for is, I will solve for a GDA problem, general duty assistant. I will solve for an A&M. I will solve for pieces of the puzzle. So the verticalization in an individual's life in the health system is reflecting in the lack of a cadre that we have, in aspirations not being modeled sufficiently. If I look at the urban area, access is available. It is affordability which is not there. That means you will get access if you have the money. So you would solve for, and that's why I said I'd probably address Ratish's. Urban Company and Asian Paints addressed a population which is able to afford. But what about those who can't afford? Where do they stand in this pyramid, right? Again, we have solutions for this. Young people, we can think gig here. We can think ways where there are, every day we meet people who say that they're getting educated. So those are places where you can bring in as a lot of part-time. A lot of the work does not need full-time. There is a cadre which is required full-time. I'm not minimizing that at all. But I'm just saying that there's a lot which can be done if we actually think that credentialing will mean better outcomes for the community and for the individual. The health systems will benefit. Both private and public health systems will benefit. And then we start piecing together what we do. But today I feel our incentives are built adversely for this. So incentive is built in for somebody who will, quote unquote, educate once and solve once. After that, if the person is dynamic, if the person is progressive, person has the willingness, will invest. Otherwise, please go through the system again, right? We push them back into the conveyor belt. So I actually see it like an escalator. So the escalator, you just have to go down and up. You're not able to get off the escalator, right? You've got to, therefore we need to reimagine it.
Yeah, no, I think fair point. And I just want to also bring it back, Gayatri, to one of the points that we've also been trying to debate here, which is, one is upward mobility. And if you look at the health sector very specifically, right, and you also touched upon it a little bit earlier, and the other is also lateral mobility, right? So given how our health system is designed, how do you see this playing out?
See, there's a whole bunch of health system which is administrative, which is actually looked down at, but needs to be thought about, rethought about, right? Simple things like how do you touch insurance? How do you move people from, quote unquote, one medical problem to the other if there are multi issues which are there? All of those issues can be very beautifully designed for lateral movement. There is a specialization which can happen because you have experience. So let's go back to the ASHA worker, right? The ASHA worker deals with women of all ages, but particularly if you look at it, in a sense, they're dealing with young people, right? Young girls and young mothers. Now, how do we extend it beyond it? The same observation skill sets can be extended to people who are, in the post 50s or 60s or later. How do you extend it? That's a lateral movement. Now, in this lateral movement, your testing may change. What do you want them to do? Is it a phlebotomist role we can teach them to do? Is it, there's a lot of skin diseases are very common in India, right? Which are very difficult to actually go and test with a dermatologist. But can we bring in some of these in order for us to solve? By no means am I saying it's easy. Refer upwards. So we tried a program for something called iMitra, which, there were two NGOs. There was Basics, us, and Essilor was the company, which we really brought it to iMitra. It's just about testing. And then you refer if you need to a hospital for any kind of intervention. But testing and certain level of prescription is possible. But the iMitra was not recognized. Now, where is the recognition? Is it in the skill world? Is it in the health system world? Is it in the consumers world? So I think the whole idea is where do you want this recognition to rest? In my mind, the consumer is the patient. The health system is the quote unquote beneficiary, right? You turn it on its table, you are able to actually design it better. But today our design is pyramidal. So each pyramid you have to rise, and if you don't rise, you're going to be at the bottom of the pyramid for the lifetime of your career. And therefore fatigue sets in, disincentivization happens, right? How many ever training programs you do, it becomes, what am I going to learn from this? What am I going to gain from this? So there is no I put for the person.
I think, and again, last point before we move to the next section, but Nachiket, if you can also touch a little bit upon how do we bring, I think you said it as well in an earlier conversation, equivalence to this process, right? So as we look at designing and, even, so the point that Gayatri made about acceptance, and how do you think about designing and planning for that?
No, my sense is that, these certifications that we imagine, either we start something de novo, which is what Cinta did, build a brand around it, build events, build rewards, build recognitions that are public, and go from there. And they have done it successfully to the point where some state governments have reached out to them to say, we would prefer that our own staff now go through your certification process than something we had internally. Because we think you have set a standard of value that is actually quite important. And this is a mechanism not just for frontline workers, not just for education. I used to be the chairman of an organization called GARP, which is for risk professionals. And GARP certifications became extremely valuable. These were not training programs, these were certifications meant for working professionals to demonstrate that they had reached a certain level of achievement. And then for recruitment purposes, this became quite important. So it's kind of one mechanism by which you go through. The other is to say that, well, if we had put you in a nursing school or in a medical school, you would have gone through 1 or 2 or 3 years of the kind of work you've already done in the field. You already know many of the things that we would have tried to teach you. Right? Is it possible to do what the National Skills Quality Framework had tried to do, which is to say, if you have this certificate, we will treat it as equal to 2 years of college, and you will get accelerated credit to get a nursing degree, to get a nursing diploma or an advanced qualification. Of course, this runs into our other problem, which is our entire selection process, as Gayatri pointed out so well, is a conveyor belt in which there is only one entrance. If you pass the NEET exam, if you pass some other exam, then you are entitled to get into this process. The fact that you know the subject and the fact that you will be able to do well does not actually feature. And in fact, almost the opposite to what is required should be happening is that earlier, for example, the DNB, the diplomas were meant for people who are acquiring practical skills. Now we've introduced NEET in that process also, so that we are restricting it now by people who know generalized skills. What Ratish mentioned, the algebra, the Latin, the Greek, whatever it is that is required to do well on that exam, independent of what you need to do well on the actual job that you are training for. So that needs a little bit of a mindset shift. But as I said earlier, National Skills Quality Framework, the new education policy actually gives us that opportunity.
Yeah. No, I think that's great. I'm just, going to summarize briefly all the things that we touched upon. We spoke about many things. We started with fundamentally how we're looking at talent models, the need for observability, the challenges with observability in the health system, and how RPL as a process can actually aid with making that visible, and particularly looking at certification, accreditation. We also spoke about RPL in terms of it not being this catch-all kind of a thing, but really has to be targeted and test for the exact competency that is being looked for. And then we also spoke about the incentives in the system, right? And some of these, incentives also addressing everything from career progression to respect to responsibility, and from a system point of view as well, looking at progression internally and so on. And also coming specifically, and I think Gayatri made the important point of also looking at incentives even for working with communities that are vulnerable and marginalized as well, and not necessarily communities that are, upwardly mobile. And finally, looking at how do we bring more legitimacy to this process and through the certification as well that Nachiket touched upon specifically here. So now that we've covered, a lot of this stuff, and I think made the case for why this is important, and also we spoke about a few examples, Nachiket and Gayatri as well covered a few examples of successful models here. If we can move to how do we, even before we get to the solutioning itself, and Ratish, maybe starting with you here, how do we even think about designing these solutions, right? So should we think about it from designing for the entire system at scale? Do we make it more modular? It'll be great to hear your views on that. You're on mute, Ratish.
Yeah. I think that one of the things that we typically do is to sort of think of this entire thing as how can we actually flip a switch and make the entire system work based on accreditation, and certification. And I think that is often a fallacy. It's never going to happen. I think one of the things I've learned now through the experiences is that finding use cases where we can demonstrate early successes, I think is going to be important. So the design principle in some sense is that design for scale, but prioritize use cases to show early wins, right? So we've talked about Centa, for example, a bunch of times. And the big moment for Centa actually came when the edtech companies wanted to hire for teachers. Because suddenly you wanted to know who are good teachers, how do you hire good teachers, how do you create incentive models for good teachers to join, etc. And once that happened, then there was a much greater acceptance of the fact that, hey, teacher certification can actually work very well, right? I say this of the classic DPI called the DigiLocker. Has always been around, but the moment it's really started seeing uptake is when DigiYatra came, because when DigiYatra, we really needed it. And I think it's important for us to figure out where is that big win that we can show where HRH can work. For example, there is a new market for overseas talent for health workforce. I mean, it doesn't address Gayatri's point of serving for the poor, but once that use case sort of sets itself to say, hey, now I can actually certify people who can go abroad, it gives us one use case to make this possible, and demonstrate that it actually works. Similarly, take one specific use case in the private markets. Like, as you know, Birohan, for example, trains health staff in the space, not regulated today by broader systems, but have established enough credibility for them to have markets hire their talent and put them in there. So one, let's not solve for the entire world. Let's identify use cases that are the biggest opportunities, show that this works, and over a period of time, it'll tick, number one. I think the second point I just wanted to make, Lakshmi, before I hand it over to Nachiket and Gayatri, is also that it doesn't have to be one national standard that works for everybody. In my opinion, I think, there's also a question on regulators, etc. I feel like regulators always lag behind innovation in any system. So let 1,000 flowers bloom, let us create micro markets where there is a provider of a certain certification and there's somebody who is willing to accept that certification. And we'll create many such systems. And over a period of time, the best one will win. And we will find a way to structure it rather than create this regulation in vacuum, which oftentimes is punitive and non-scalable, And that's another way to think about this approach as well.
Interesting. So thanks, Ratish. So Nachiket, if coming to you, if you can also help, if this is, the broader thinking, one, it'll be helpful if you can expand on this and also break it down for our audience to say, what does this really mean, right? So if this is an approach that we need to take, and let's say we're taking 1,000 flowers bloom kind of an approach, how does one start?
I mean, my own sense is that we already have regulated entities in the system called universities, for example, that are all over the place. There is a large community of universities that the system has trusted to award degrees, award diplomas, award courses, right? what I really liked about what Swastika Swaraj did is they went to such a university called Centurion University and developed a program that Centurion was comfortable saying this is a diploma in community health practice. There's a lot more innovation there. They collaborated with Swastika Swaraj to build a program that truly reflected many of the things, Gayatri was talking about. What is the actual competency needed? What is the actual skill set that is needed, right? Are there any gaps? It's possible that 80%, but 20% you need to do training. It's possible 20%, 80% you need to training. All of these possibilities, they accommodated right, to try and build this network. Now, one danger of 1,000 flowers blooming is that how do you establish equivalence? How do you build a market? How do you make sure that people have a sense of, is this diploma the same as that diploma? Is this, which is what the degree kind of, tries to do. But that I think we can solve slowly. I mean, as you saw in engineering, right? Thousands upon thousands of engineering colleges emerge. We knew upfront itself that not all of them are the same. Now many have shut down. Many are producing graduates that are snapped up within days of graduating. Many are seeing 30% acceptance rates, right? So it's possible that some of this, the market will figure out. I certainly see a role for maybe an informed, proactive regulator to come in and say, because there's a little bit of a risk that you start to get people signaling low quality programs with the false hope that this will give you this job, this will give you, we have seen this in the global market situation. We could certainly start to see it in the local market, right? But maybe after some amount of work has already happened, after some data has started to emerge to say, what is it that is needed? Because today we don't even have such a clearly laid down program in place. And that will have to be the first. And I would certainly turn to people like Gayatri who have years and years of experience of understanding competency assessment, and its competencies on the emotional side, competencies on technology side. My own belief is that as we face the future, 2030, 2040, 2050, we're going to need a health worker that is highly technologically equipped, but combines that with deep understanding of the social, cultural realities of the populations that she serves, right? Now, how does one combine these two? And as she correctly pointed out, right, a lot of communities, both in rural areas, remote rural areas, but also in urban sub-communities, migrant communities, you're going to have to turn to somebody from the community to be your partner. Right? And that's really where the opportunity for certification comes.
No, certainly. So I'm just going to, again, go back to you, Gayatri. And, if we were to break this down and if we were to start, like Nachiket said, identification of competency, looking at then figuring out exactly what the problem it is that you want to solve, identifying, saying these are the skills that are needed to solve the problem, and then looking at actually creating that framework. Can you also give us an example of how that may have already played out in the work that you have done, Gayatri?
So I think before I go there, the education system in India is actually is ideal for it. The state boards, 84% of our students come out of state boards. It's not the CBSE and the ICSE which give, there's only 15%. That means each state board already functions in the school level, right? Which means you have equivalence, which is across state boards, and each state board, is graded good or bad differently. But people come out of a state board. Universities are actually highly regulated and are geography specific. Very rarely can they go and just award a degree across, which means the whole national education policy, if you overlay it, which actually says this, saying that you have multi-entry, multi-exit. So in theory we have it. In practice we have a school education and a university education which is localized, which means we should be able to imagine it and make it happen. So this is happening in the medical. The The challenge is it is always fixed in context of a hospital. Now, if you bring this down to the sub-centers and wellness centers and see what's required, you don't possibly require everything which is only complex testing. You need a lot before that. I think if we can sort of, put a, scale and say, okay, what are the things which can be done and which requires deep training, deep specialization before one touches, then I think it's possible for us to do. The danger is always there, right? You've got to be careful. One mistake could cost, and therefore the entire thing can get derailed here. So one needs to be cautious. You need to have regulation. I'm not for 1 minute say that take the regulators out of it or don't have it. But I think the larger thing is we can fit it into our education system. If we fit it into the education system, one can actually call out which are the ones which is possible for us to do. And then look at it also systemically, right? I'm a big fan of the Japaigo model. The way in which the maternity room is certified by, and everybody is involved in the certification, from the person who cleans to the person who's the nurse to the pharmacist to the doctor. And it's a regular accreditation. You have to recertify yourself after a period of time, which is a beautiful way of actually making systems work, which means each is certified on a competency and you can actually move up or down. The problem there is, again, because the system is geared towards qualification. I think take the qualification out of 50 to 60% of the roles and say these roles can function, and then 40% of the roles require qualification, require upward mobility. I think it's for us to reimagine it. So take the pyramid and the triangle out and actually start imagining. In my mind, I always see it as a pizza, right? You have a pizza, you have layers. Very bad analogy, but there is there's a stadium in the UK which actually pulls out as a dance floor. It comes into a football stadium, and there are multi-uses for it, right? So we've got to think like that. We've thought about it in our engineering mindsets, but when we think about it for our health systems, we tend to think very linearly. And you could look up this stadium. It's something I've always been fascinated about because it's the useful use of space for multiple events. But if we start thinking of our systems, spaces, and our people in that manner, I think we have it because the NEP allows it. The National Education Policy allows it. The university system exists. The school system exists. Then it's only us not thinking of credentialing. We haven't designed it right. And that's the only, which is not, in my mind, an impossible place to be. It's possible to solve fast, and it's possible to solve quickly.
Oh, fantastic, Gayatri. And so again, I think we agree that it is going to be a 1,000 flowers bloom kind of a model to start with, at least, though we recognize that some dangers of that exist. We also broke down very specifically in this model how we actually execute this in terms of exactly identifying the problem that we want to solve, the competency that we want to build, and exactly what we want to certify. We also discussed how there is an enabling system that allows for this to flourish, right? Which is the NEP policy as well, that both Nachiket and Gayatri, you alluded to as well. And finally, how do we actually reimagine this creatively, keeping in mind the constraints, but at the same time, the existing layers and structures, Gayatri, that you talked about just now. I now want to move to, before we get to the questions, just spend 5 minutes, if, given that we have a varied audience, a diverse audience, so we have people from the philanthropy community, we have implementing nonprofits, and we have academia. And this is a question to all three of you. Starting tomorrow, what should each of them do to make this happen? And any of you can start.
I could go first because the more thoughtful answers are going to come after mine. I think that for me, there are two parts. People who are going to be able to make this happen and people who are going to support this to make this happen. I think for those who are supposed to make this happen, for like we discussed here, I think taking this entire idea and framing it in a particular context is what is going to be able to demonstrate this whole picture, right? So if you are an innovator who believes that this has to be done, I feel like 5 things have to come together. First is identify that opportunity where the differentiated value can be. And that differentiated value can be, to what Gayatri said, to be able to say, hey, in X number of villages and blocks, we're going to have a far more effective quality health experience that we're going to demonstrate. But I think frame that opportunity that is a value that has to be unlocked, number one. Second is identify the workforce for which you're going to build that scaffolding, both in terms of career pathways to demonstrate this and certification, right? Third is find the provider of, find that university model that Nachiket is talking about, the entity that can offer that certification, right? Fourth is figure out the supply and demand for this, like who's going to enable that model, like what nonprofits have been able to do that Nachiket has been highlighting, and who's going to absorb that talent, like figure out that supply and model equation. 5 is just demonstrated with evidence that can enable us to scale. If we can get these 5 pieces together across multiple contexts, like I said, overseas talent, model village, block, urban, particular diseases, whatever that model will be. But I think demonstrating this model of certification resulting in higher outcomes across multiple contexts, I think will be valuable. I think as philanthropists, just investing more in this space, I think is very, very important. I think some of them are on this call as well. But essentially, we need a lot more people to support innovations in this space. That, like we started in the beginning, it is not the lack of people, and it's also not the lack of need. We need a far higher quality experience than we have right now. It is the systems, the human health systems that we have to build that will help us deliver that. And so investments in this space, in interesting pilots, potential scale-up opportunities, and for some of the donors to also bring their social capital with industry and governments to be able to demonstrate these models that individual innovators may not be able to do will be very, very helpful.
Thanks, Ratish. Gayatri, Nachiket?
So I was just thinking, see, just look at the problem that is there, right? And I just want to take an analogy and sort of stick to it. Just assume there is pneumonia. Now, we never think this can be solved at the community level, but there have been examples. In Rajasthan, there's a doctor called Pavitra. They have been working with community-acquired pneumonia and how do you solve in primary healthcare settings. So, the gradation of who is going to do what and when do you refer to hospitals? How do you decongest your tertiary by actually building strong systems of people who are capable of actually a lot of the care work, lot of the diagnostic work, which technology will bring in. So, and that's where I'm coming in from saying that technology, education need to be married together with outcomes of what we want. I called it community acquired pneumonia. I don't know whether that's a right word, but what I meant is there is large scale, the population was affected. This is a research paper which is well written about. There's a podcast on it. I'm not saying something which I know, which has just been built up. The COVID was a time. We took in a lot of people and we trained them to, we did almost 50,000 people. We trained them to do nasal testing. And we deployed them all along the borders of 4 states. We were literally, quote unquote, manning the borders. So I'm just saying that it is possible for us to do, but it's always to look, and I would agree with Ratish, there is a requirement. Germany says they need 400,000 people in the healthcare and allied sectors per annum. In that case, there could be other aging countries, and that could give us the upward mobility for at least 5% or 10%, which creates aspirations. So can we train here? I'm not saying have incompetent people in India and low medical care and low healthcare in India, but not poor quality. But at the same time, one needs to start imagining differently. And I think the whole thematic today is, let's not think only teaching. Let's not think there's only one way of learning. If we go away from one way of learning, then credentialing becomes the problem we have to solve. I'm sure we will have very innovative ways of testing for it. Then is incentivization, right? So pathways could be many. And some people may need part-time, which is okay. And they will remain back. Those who will need upward mobility to move. So lateral upward mobility could go outside the country, could remain within the country, could serve different populations. So it's for us to actually sit back and design good assessments, and not be, I mean, I'm actually tired of MCQs. I just think get away from it. Put miners' hats with cameras and videos, and let's do it intelligently.
Yeah. So what I'm also taking away, Gayatri, is that this is one of the core things that needs to be done, right? And this is also speaking to the audience as well, and supporting these initiatives and even in redesign and imagining how we want to execute this. Nachiket?
No, I'll just build on some fabulous comments Satish and Gayatri have already given. I would say if I was a philanthropist, working with some nonprofit, whichever part of the country, the good thing in India is we have no shortage of benchmark, high quality nonprofits. Be that Search in Gadchiroli, be that basic healthcare services that Gayatri referred to, run by, the Mr. and Mrs. Dr. Pavitra Mohan and Sanjana, JSS in Chhattisgarh, beautiful, wonderful, deep competency organizations. I would go to them with resources and say, we believe there is a value to building this certification process. Can you design something that you are comfortable, that you would be comfortable, because they all have health workers. They have different names for them, Sakhis, something else. Everybody has different names. Healing Fields has a very large program right out of Hyderabad. They all have deep understanding of what is required. I think that's where we would start. There are local universities, they know well, right? Collaborate with them, build a program that meets with the kind of, requirements that Gayatri pointed out, Ratish pointed out. I think that would be a terrific starting point, where you started to say, then start to think about the National Skills Quality Framework, the equivalence idea, which universities are very good at. As Gayatri was saying, we are actually well prepared in terms of infrastructure to do this well. We are not using that infrastructure very well. I wouldn't necessarily say we need a national regulator. It's entirely possible that the emphasis in a state like Kerala is much more on diabetes and on mental health. And they're really focused on those issues. Whereas in remote rural Rajasthan, the focus is on tuberculosis, which they are acquiring through the temple making activities that they are all participating when they migrate to Surat and other places, right? So every place has a different emphasis, and how does one think about it can vary. But the common theme will be that we'll start to build the components. If one wanted global benchmarks, I've already mentioned the Alaskan program. It's a formal certification. You can actually download the 20-page document that says, this is required for level 1. This is required for level 2. I'm not saying that's relevant directly for us, but if you want something that looks like a structure, that structure already exists. I think eventually, with the help of regulators, national bodies, etc., and people like Gayatri have so much experience of this, we can bring some of these ideas together to say, okay, we have built these. Now, can we start to build a national layering of some of these issues? I would prematurely not start with national, because actually the reality is each state, language, so many issues will be important.
No, I think that's quite practical, Nachiket. And I think you also touched upon the very important point of localization, right? And solving for local challenges. I know, I'm mindful we have only 15 minutes and we have a lot of questions coming in. So I do want to make sure that we touch upon some of the critical ones. There is a question from Dr. Anuradha Jain around looking at how do we think social systems govern the skill hierarchy, or for that matter, the whole education system, and how can that be addressed? With a follow-up question on why we are not encouraging open school systems supported by certifications. Maybe Gayatri, if you want to address that, and then, or anyone else? Nachiketa,
So I
Satish?
think, Anuradha, one of my favorite things actually nowadays is to start looking at behavioral communication. And, it used to be called development communication. But if you look at several of these things, skills is all related to the aspiration, right? What do I gain by getting it, and how does society view me? So if you make several of these interesting, then I think the skill hierarchy can be broken. So I'll just take a minute to explain it. When you think of a midwife or a A&M versus you think of a nurse versus you think of a doctor, even in language, it'll come in as he and she. You have a lot of male nurses now, but the language is still not there, right, for it. So I think it's about us changing a lot of those. Skill hierarchy will change when we're able to actually communicate several of these intelligently. And some of it can be very interesting, old style mascots that we have. And I think today that, the K-drama actually allows us to do. If we think intelligently, we should be able to apply several of these in very, very, very interesting. And I just sort of take a minute on the example that we had. We had a very interesting experience we did with about 40,000 kids with the tortoise. We called the tortoise, Ujjwal. It's just got a light on it. The energy is what we were trying to communicate, and there was huge change on how they viewed electricians, how they viewed, the very fact that energy is not only electricity. It can be generation, it can be saving. It was a whole bunch of things you can communicate, and therefore careers through it. So I think that would be very applicable to something like this. I think AI definitely, according to me, as that's what I was saying, right? I feel it's not enough. We don't appreciate it. Given the amount of video-based assessments, which can be done intelligently if we're taught how to actually use it. And then, of course, you need to, it needs to be curated. It just cannot be taken in, but peer-based. These are systems technology can really facilitate. So I think it's about us, as I said it earlier, it's about us to imagine how we want to test. It's about us to imagine how we're going to call out those careers. If it is a dead end, if your GNM is your dead end, if your ASHA is your dead end, your Anganwadi worker is a dead end, then it's sort of, then it's a problem. So I think our solution lies in us saying it's not a dead end. And if we can say 1,000 people, we've been able to move out of it and there are career paths, I think 3 years will be enough, or 5 years will be enough for us to show enough evidence on that. But for that, you need, unfortunately, I think philanthropic money needs to be more research and development oriented so that one can test out these things. You're not going to get it right the first time. So one needs to test it out, and you may have a few failures, but so what? Learn from it and then apply it and move forward.
Thank you, Gayatri. Nachiketa, Satish, anything to add to this?
No, so there's another question that Yashasvi put out that I thought maybe I can move on to, because Gayatri responded comprehensively to the previous one. Is, what do we need to do to trigger the market response? Now, it depends on the scale of effort we want to put in. As Gayatri said, if we can show impact over a period of time, even in 3 or 4 or 5 locations, there will be a natural momentum that will build, because people will want to move forward with this. But if you want to accelerate this, I would really borrow from the playbook of Cinta. They used a lot of public media, public recognition of these certificates, so that these certificates became really very valuable to people. Because it's not simply a matter of being valuable to the trainee or to the person being certified. How does the market know that this certificate actually exists? Whether it is meant for the international market, my own focus is on the local community-based provider. How does anybody know that these certificates exist? For example, Swasthya Swaraj has done a terrific job of the diploma in community health practice, right? One of the challenges they have, and which people like me, many others are helping them, is to make sure that that certificate is made known to a broader community of people that are interested in such capabilities. Because some young women will say, I'm happy living my whole life doing what I'm doing now. Just pay me appropriately. Some will say, no, I actually would like to move out and contribute to a larger health system with my deep knowledge and my understanding of what is required on the ground. And both in a way form an equilibrium, because some people are leaving, the others' compensation goes up. And because some people are staying, there is a balance between people coming in and going out. So I think that will be needed. And again, philanthropy can play a big role, coming together, making sure that there is an understanding of what are we trying to do here, using multiple tools to evaluate people, build those techniques. We have very nice capabilities that people like Xstep and others have built to do micro-credentialing, to do tracking, to do portability of these micro-credentials. That's the beauty of where we are today. We have so much of infrastructure, so much of capability that it really needs a little bit of a spark to get going. And I'm convinced that this will, become a movement fairly quickly.
Thanks, Nachiket. I think, there are a couple of questions around regulation, Nachiket. One, I think you've already answered, but if you can elaborate a little bit around that. And there's also a question from a regulatory standpoint in terms of, having some of these partnerships even locally with the regulatory ecosystem and ensuring that brings in recognition as well, right? So I think touching upon the regulation aspect from both these lenses, perhaps Nachiket, you can address this question.
I would go, regulation is a broad word. It means many things to many people. As I said earlier, the universities are regulators because you can't get a university degree, you can't get a university diploma without passing the internal quality control mechanism of the university. We don't need police and that kind of regulation, judiciary. This is a regulator, and rightly so, because it puts its brand at risk. When you say, I've got a diploma in community health practice from Centurion University, right? So Centurion is saying, I am actually the person, in a sense, regulating this overall effort. There's clearly an opportunity. There is a challenge, I would say, of premature scale, because as soon as you now make this a system in which lots of, contract type organizations come in to do the skilling, and then somebody else certifies them without the protection of a university, then you have to really be careful that people are not getting cheated. We have seen this happen in the nursing cadre, where people are, they get a loan, they join in, they find that the actual school doesn't exist, and they got misled with this. Which is why I would go, which is one of the reasons I like the certification first approach. And training following it. Because if you certify, it becomes pretty clear to you, does this certificate have any value or not? If it has value, then that sense of value disseminates fairly quickly. And then more people would like to get that certificate. Some of them may need training, some of them may not need training. Right? So in a way, a certification first approach already is regulation friendly. And then, of course, as we start to build a larger movement around it, one will have to maybe create a self-regulatory structure. I wouldn't even necessarily say we need outsiders to come in and regulate it, because there's already the university system that's engaged. Not so much to regulate, but to build fungibility of certificates, to say this standard is equal to that standard is equal to some other standard. National Cancer Grid does a beautiful job with no regulators involved of ensuring that all the grid hospitals have a common capability of, say, oncopathology, by making sure that they send samples, gold standard samples to it, gold standard, tests to people, make sure that they evaluate them, and use their brand as National Cancer Grid to put this together. I would say these kinds of opportunities would be the opportunities I would stress, rather than bringing in kind of punitive regulation. Maybe that's something that, once it starts to acquire some amount of momentum, then we have to see, how do we build a structure that makes sense. But for now, I think there's enough already in the system that we don't need to worry about
Ratish, Gayatri, anything to add there? One of the areas that I also, I think that came in earlier as well was around looking at very specifically marginalized populations and tribal areas, and looking at, I think a couple of people have brought up the point around absenteeism and fundamental motivation issues for health workers in that region. Would you imagine this type of a model or this type of an approach to also apply there? Is there something else that we need to consider for some of these regions differently?
So I mean, this is what Lakshmi was referring to, right? These are the 2.5 lakh, which is not economically considered to be, they're not sustainable. That means they're going to be smaller populations which are out of reach. Distance itself is going to be an issue. Several factors are going to affect it, and absenteeism is one of it, because buses stop at 4 o'clock. Access of anybody who's going to be posted, which means you need to have communities built up. And I think the paper, the conversations on Alaska by Nachiket is absolutely the right thing. It's the same issue in a different context. So one needs to build, and these are systems, if we actually do it right, these are the very populations which will benefit. And they will benefit hugely by having competent, good people providing quality healthcare. Whereas today they have to depend on someone who is willing to go there. So the willingness to go is a sacrifice. If I'm there, I mean, you ask me to go there and live there, I am making a sacrifice, right? Whereas the person who is from there, if for them it's incentivized, in order for them to get recognition, the whole issue changes. And I think on the chat which is put is a very relevant one, but I think that's where these models work very well. And they've been demonstrated. I think they've been demonstrated. It's not like we don't have any examples. We have very good examples. It's for us to take it, and we don't need everything to be one monolithic model. It can be models which are developed around it and make that work. But it is fungible. It can move from one place, Rajasthan, to a tribal Maharashtra, or Bidar in Karnataka, or whatever. It can move to Northeast. It's possible to get it there.
Wonderful.
Just two quick comments from me. One is, just building on what Gayatri is saying. Even the army has the notion of the battlefield nursing assistant, right? When a platoon is posted in Siachen or somewhere else, one of those members is trained to provide first aid, to provide emergency care, to keep the person alive, right? Very much in the spirit of, I would not post another nurse there to Siachen, because not anybody wants to go in that hostile and very difficult terrain. Those people who are already there, can actually make such a difference. The second quick point, some of the comments I'm seeing, which are very valid comments, which is to say there is no infrastructure, there is no machine, this is not a panacea to solve all problems. We have to fix those other issues as well. It's not as if you put a good person there and they don't have the ability to do any blood tests. Well, that's not going to solve the blood test problem. This is an important building block as a part of a jigsaw puzzle that we are building for the healthcare. This is an important one. But I would not want to go to the extent of saying, once you solve this, it's a silver bullet, everything will get solved.
Absolutely.
I think I'm going to have one last statement before I think just in terms of building this as well, it'll be good to think about what is the context-independent infrastructure that we can build for this. And what Nachiket hinted upon it, and I just want to build that. We can even build this better than the current accreditation certification system that we have, which is a digitally verifiable infrastructure that essentially is available. So even if there are multiple agencies, you can actually validate whether it's actually true. Like somebody like me who doesn't know Centurion University exists, I can digitally verify whether it exists and whether they've actually provided this accreditation. That is context independent. Context dependent, Siachen battle assistant, tribal local healer who can be certified, to Jharkhand women problems, global German. All of these are contexts, and we need entrepreneurs who can make it work within that context. I mean, it's easy to say we should do it, but they have to make it acceptable for the society, viable as a model, all of that. And I feel like We need a lot of entrepreneurs to take individual context and solve for it context-dependent manner. What we can enable them is with the context-independent infrastructure that we can build, which can actually be better than what like my certification is, which is from a university that nobody can check. They just have to trust me to say, yeah, that probably is true, right? So that's what is the opportunity here.
I think that's a great place to close. Thank you so much, Nachiket, Gayatri, Ratish. It's been absolutely wonderful to learn and hear your thoughts and insights, and to our audience as well for being really engaging with the questions both pre as well as during the session. And would request, if you would like to know more about this, if you'd like to engage more on this, very happy to connect with you offline as well. Please do reach out to us. And we'd be happy to set up a conversation. Thank you so much once again for this discussion.
Thank you, everyone.